me to talk. They said, well, do you have any slides? I said, well, I'm going to show some tomorrow. They said, well, do you have any slides for the news conference? And then I said, well, no, I really sort of want to just talk about it. And then I realized how uncommon it is for anyone to come to the American Heart Association and not show slides. The truth is that I can only think of two professions where it's routine to talk about very complicated concepts and not show slides. One is the clergy, and second is politics. And you can figure out what they may or may not have in common. Anyway, is the American Heart going to get upset with me about? No, okay.
You want to hear what you have to say?
Okay, great. I want to congratulate Dr. Bart and his colleagues for really a terrific study and an important one. Remember that the goal in acutely decompensated heart failure is to get fluid off of the patients. And the question is the best way to do that with drugs or with a device? Is the best way to do that with diuretics or with a mechanical system that pulls fluid out of the circulation? Now, this mechanical system called ultrafiltration has been around for several years, and it is a system similar in some ways conceptually to dialysis. It mechanically pulls fluid. It can do that rapidly or slowly, and it has been used successfully in individuals who have been unresponsive to diuretics, those who get diuretics, and the diuretics don't work anymore. The ultrafiltration has started, and the fluid can be pulled off in patients previously unable to have that done with diuretics. And the question has not been whether those individuals can be helped by ultrafiltration. The question that Dr. Bart and his colleagues asked is, in individuals who are responsive to diuretics, can the mechanical system of ultrafiltration be as good or better as reasonably initial therapy in these individuals? If mechanical systems are better, then we shouldn't be spending a lot of time trying to use diuretics in these patients. We should go to mechanical system much earlier during the hospitalization. There's been a previous trial trying to compare these two, and the results of that trial, called the UNLOAD study, indicated that perhaps you could pull more fluid off of patients with the ultrafiltration system, but there was concern in that study as to whether the diuretic doses that were used were appropriate or even optimal. And that's why Dr. Bart's study, the CARRESS-HF study, is so important. They optimize or try to optimize both arms in order to make this a fair comparison. And what they found was, as initial therapy, or reasonably initial therapy, that the amount of fluid pulled off was comparable in the two groups. A little bit more with ultrafiltration early, but a little bit more with drugs during long-term follow-up. What was more surprising, perhaps much more disconcerting, was the fact that when fluid was pulled off with the mechanical device, renal function got worse more with the mechanical device than with drug therapy. And when you see his graph of renal function, you will see during the entire duration of follow-up, renal function was worse on ultrafiltration than on diuretics, and that difference persisted even 60 days after therapy. We don't know why this should be, and we don't know to what extent that contributes to the increase in serious adverse events seen in ultrafiltration. Certainly, the patients with ultrafiltration are getting heparin. They have other issues that might be important in terms of rapidity of fluid removal, but the worsening renal function really is a concern here, particularly since in some patients it appears to be reasonably long-lasting. So I agree with Dr. Bart and the investigators of the CARRESS trial. As far as these data are concerned, they offer no support for using a mechanical system of ultrafiltration in lieu of using diuretics in patients who are responsive to diuretics. I still think there's a role of ultrafiltration in patients who are diuretic unresponsive. Thank you.